We'll go ahead with an hour, a little less than an hour of questions. And I think we'll just start with a basic question. I know allogeneic transplant can, and you might all want to respond, and that's fine. Only one person might want to respond, and that's fine too, because we do have quite a few questions. For patients who are doing allogeneic transplant or have had prior allo transplant, a lot of them are not allowed to go in clinical trials. So what's the status for most of the open CAR T? And then after, just when the drugs are introduced and are commercially available, does prior allo have any impact on CAR T?
So I can start with this one. So for most of the clinical trials, prior allogeneic transplant is excluded, but for the CARTITUDE study, and I know the JCAR study, they do allow prior allo. It has to be after 6 months of the allo, and they can't have any active graft versus host disease. So if you don't have any of those, then you can still do CAR T trial after allogeneic transplant. And we've had patients who went on the study with that, and they've done just as fine, and they're in CR after. So having a prior allo did not make their CAR T any worse, their cytokine release syndrome, or what their response.
Dr. Munshi, Dr. Vij, any comments?
No, absolutely. I think we are all beginning to have this possibility. They shouldn't be on immunosuppression, as Dr. Madhuri said, and they would be similar candidate as those who did not have allo transplant.
Yeah, that's great news. And I'm glad on these trials. I didn't know that. Dr. Vij, did you have a comment?
No, I agree. I don't have anything else to add.
Okay. Another question is about a patient. This is from Alan. His wife has had 3 heart stents put in. Are there specific comorbidities that are worse than others for when you consider CAR T, including heart conditions?
So I think that, again, one of the main things to avoid a CAR T perhaps is in a patient who's got an active infection. I think that it would be one scenario where you don't want to take a patient into a CAR T if they have an active infection. As regards the organ impairment question, I think that CAR T cells don't usually have direct effects on organ function, but the fact is that because of CRS and other complications that can set in, you do need to have at least a moderate amount of cardiac reserve to be able to overcome sometimes the toxicity that CRS or other side effects that the CAR T produces may be encountered. So I think that just the presence of stents is certainly not a contraindication to doing a CAR T cell. It is more that if the cardiac pumping function is impaired, and that too if it is severely impaired. For most patients who are doing well managed on medication with cardiac issues, CAR T cells should be able to be delivered.
I think the thing that is coming up, Jenny, is that do we need patients to be in as good a shape as we needed for transplant? Mm-hmm. And the answer is that, as Dr. Vij suggested, answer is not necessarily as restrictive as what we are for transplant. We could have a little bit more liberal criteria for the heart function and the lung function and other. Very rightly, what Dr. Vij said, infection is something we have to be careful about because of various reasons. But other than that, I think we would have a better ability to do it with a little bit lesser cardiac or pulmonary function.
Well, let me ask a follow-up question to that then. So CAR T in the age of COVID, what precautions do you suggest patients take? Are they more immunocompromised because they have CAR T? Is it for an extended period of time? Is it for a time period? What do you think about that?
So I can actually answer that because we actually had a patient that was going through CAR T, and as you know, New York City got hit pretty hard with the COVID situation. So we had a patient that we screened. So our hospital requires you to have a COVID test and as do the clinical trials before they go on. The patient had a COVID screening test that was negative by PCR, then had their baseline evaluation. And then before you get admitted to the hospital, they have to have another COVID screening test, which he got both. PCRs were negative, started lymphodepletion. First day tolerated it fine. The second day ended up, when they came to clinic, had a fever. And so then we were like, oh, is he really going to have COVID? Should we test him? But we ended up testing him anyway as we screened him for other infections. Just like Dr. Vij said, we want to make sure that there's no infection going on. And the COVID PCR came back positive. So he actually ended up having a COVID positive test despite having a negative one like 3 days before. So we ended up admitting him to the hospital, and because he was neutropenic, we wanted to monitor him closely. He actually did pretty fine and got discharged within a couple of days. The fevers went away. He didn't really need a lot of oxygen. So he was just quarantined at home. And it took about 5 weeks for his COVID PCR to turn negative. And because of the whole total pandemic in New York City, because this happened right at the peak, we delayed it. We kept just checking his labs every week as we did his PCR, thinking, do we need to give him more bridging chemo if his numbers start going up rapidly while we wait for this pandemic to calm down? But he ended up staying okay without any more bridging chemotherapy. And 5 weeks later, he cleared his PCR, and things calmed down a little bit in New York. Underwent CAR T cell therapy, did totally fine, and he's like in stringent CR now, doing really, really well.
Great.
So, the hospitals really do require you to have the COVID PCR testing done, and the trial requires you to have that. Plus, you want to make sure you have 2 doses of tocilizumab on hand for these patients that go through CAR T. And during the COVID time, a lot of us were giving tocilizumab for the CRS for the COVID. So that's one caution that we have to make sure that the hospital keeps in track when you're going through CAR T during this time.
Mm-hmm. And we had somebody ask, oh, go ahead, Dr. Munshi.
No, I wanted to answer, add to, in a different way to the COVID related question. So I think one of the very important things we have learned in 6, 7, 8 months globally, so we had this International Myeloma Society with all Dr. Vij and Madhuri and all our colleagues have been part of, we have put good data together to understand. Initially, we stopped doing things. We stopped doing transplant. We stopped doing CAR T cells. And as far as possible, even stopped giving injectable treatment so patients don't have to come to a hospital. That was the first 2-3 months time. But during that time, we all collected our data to understand what's happening. And one short answer or suggestion would be that what we have realized is that the best way to fight COVID for myeloma patient is to control their myeloma well. And so we have an editorial coming in one of the medical journal, which says, don't compromise your myeloma treatment during the COVID pandemic. Your good myeloma treatment, taking all sorts of precautions, like doing the testing, etc. We should control it. And having good experience from the European side and our own, mainly as Dr. Madhuri said, some of it from New York in the initial days. Now we are safely doing transplant, we are safely doing CAR T, we know what precautions to take. So for the larger population, people on this call, it can be safely done. And people who are doing CAR T right now, they're all very good centers. They know what they're doing. They know what precautions to take. So if suggested, I would have and if clinically and medically right decision, I would have no hesitation in having a patient go through go through CAR T cell therapy.
Mm-hmm. Okay, great. Another question I know that the requirements for clinical trials are a certain number of prior lines of therapy before you enter the trials. When these are commercially available, there will also be some guidelines in place, right, with what people have had to have for prior therapy. So if somebody was transplant ineligible and had several sets of CAR T therapy or of regular combination therapy for myeloma and is in, MRD negative, no M spike, do you do CAR T? Like if you could do it, would you do it? Or do you just wait because you don't know how long you're going to be in an MRD status? Or I don't know, for patients, it's really tough because you're always kind of playing this waiting game. Like, well, did I relapse now? Well, did I relapse now? Is there something I can do to give myself a longer time frame?
I think that as far as CAR T for patients who are not had a transplant, certainly they could be candidates for a CAR T after multiple lines of therapy has failed, and they meet the FDA definition for the administration of CAR T, because that is one thing that insurance companies will demand, given the expensive nature of this. Now, in the future, could you, as we discussed, move it into an earlier line of treatment? Yes, but I think you need the evidence that it is better than doing something different. I think that Logically, it should be, but we can't assume so. And these therapies are associated with some side effects. Yes, by and large, the CRS and the neurological toxicity is less than what we have perceived with CAR T cells currently commercialized for leukemia and lymphoma. But there are patients that have sometimes serious side effects. So I don't think we should take this lightly till clinical trials show their benefit in that earlier line of treatment.
Mhm. Okay. Another question by Wade, and we've talked, I think, Dr. Maduri, you covered this really well in the presentation about other things that are targeting BCMA. But if someone's using the Belamaf or Blenrep product, which is BCMA targeted, and then wants to move to, that fails for some reason, wants to go to a CAR T therapy, how likely is that to work? Or like what you were saying earlier, Dr. Maduri, you're talking about, well, we're going to do the people using let me say it right, GPRC5D first, and then move to BCMA therapy. Like, would you ever consider just going to another BCMA therapy and just hope it works?
I mean, I think that's the question that it's on everybody's mind right now, right? Because the field is so saturated with BCMA therapies, whether it's CAR T, and in the CAR T, there's multiple different BCMA CAR Ts, and then you have the bispecifics, and then you have the ADC that's already approved. Plus, there's other BCMA ADCs in the clinical trial space right now. So I think it's a really hard question. But like I mentioned before, I mean, if you have somebody that doesn't have a spot on a clinical trial and they're progressing and you have this BCMA ADC therapy, I mean, you have to do what you have to do that's best for the patient, right? If there's no other therapies you can offer them. And most of these trials, like I said, are now opening arms that allow prior BCMA cohorts. Unfortunately, most of the trials now are not as much in relapse refractory and they're more in the earlier lines. And we hope once the first commercial CAR T comes around, maybe in March or April of next year, like Dr. Munshi was mentioning, then this patient can do BCMA ADC. And if they progress, maybe they can just go on to commercial CAR T. And there, it's not a clinical trial. So you can put, whatever patient you want to put on there as long as they're healthy enough to have CAR T.
Mm-hmm. Okay.
So,
go ahead, Dr. Munshi.
yeah, so I think it's important for us to know, as Dr. Madhuri indicated, that losing BCMA is not most common reason for a BCMA targeted therapy to fail. So if somebody gets BCMA CAR T cell therapy, except for a small number of patients that each one of us has one or two patients like that, most of the patients' myeloma cells are still expressing BCMA. And so then you can go to something else subsequently. The failure have many other reasons, but losing BCMA is not the commonest one. And that's why we can go successively to other treatments. Currently, we don't want to give because current protocols used to prevent us from putting patients on BCMA CAR T if they had a BCMA targeted treatment, but not so anymore in some of the studies.
I didn't know that losing BCMA wasn't the reason.
That's not the commonest at all.
Yeah, that's fascinating. Totally fascinating. Dr. Vij, I have a question for you because you noted that some drugs do damage T cells. So can you identify like if you're trying to wait for CAR T to become available, are there certain things that you can avoid or you can kind of manage your way around so that by the time you go to get the T cell therapy, your T cells are in good shape?
I think that, again, you do have to treat the patient with progressive disease with the best treatment possible. I think that in most cases, trying to avoid exposure to a certain agent would probably not be in the best interest of the patient, just if their disease is progressing, especially if it is progressing rapidly. Only thing I can say is that some patients are treated these days in myeloma with bendamustine. There is data from the lymphoma literature that suggests that bendamustine exposure immediately prior to manufacturing of CAR T, the pheresis, may make the yield of these T cells, may compromise it and may lead to failure of manufacturing. So that's the only piece of data I think that I have, but I would be interested to say what my colleagues say.
No, I think you're very correct. I think some of this DNA damaging agent, which, as we call it, like bendamustine, can have some impact. There is some suspicion that in myeloma also that is observed indirectly. And it's not just the number of T cell. We may get enough number of T cell, but their health may be in some ways affected. Now, we don't have a very good measure of saying whether this T cell is a good T cell or this is not a good T cell. So the only way to find out is to try and make CAR T cell, and in the end may make it or not make it. But there are some studies, ongoing studies, that are trying to find out characteristics of the T cell to understand if there are features of the T cells which are preferred versus not. But I think, as Dr. Witt said, giving any of the cytotoxic agent might have effect. We don't have good data on immune modulating effect in the sense if patients got an antibody, we don't think there is any significant impact that we know yet. But I think some of those things are also being studied. And I think, as Dr. Vij earlier said, when we make the CAR T cell, what kind of T cells are we making? And there are various types. There are CD4 positive cells, CD8 positive cells, and each one of them have certain function. And there is beginning of research that says maybe we should have more of one versus more of another. So what patients get before can also be possibly overcome by combining something after making the CAR T cell, if we are able to make enough CAR T cells. So there's a lot of good research happening to overcome this, but I agree, toxic treatment should be, cell toxic treatment should be avoided if feasible. And I think what Dr. Witt said is very, very important statement. We have to do first what is best for patient.
Mhm.
And then we do whatever we do for the next treatment.
Yeah, that makes a lot of sense. Is there an immune panel that can be run to kind of assess the status of your immune system or the strength of your immune system prior to CAR T? So you get a better idea as we get more practice, because you're manufacturing these cells, and then at the end you're going, okay, how many have been manufactured or look functional or whatever?
At the moment, there is no, I mean, we have in our lab, we have very many good panels to study that,
Mhm.
but nothing that is good enough that can and should be applied routinely to know the immune status. What in an indirect way, what sometimes we look at is how many lymphocytes are, what we call absolute lymphocyte count is what we look at, just as a bulk number, but not to find combat that what is within those lymphocytes, how many are certain subtypes of lymphocytes. So we know all sorts of subtypes, but there is really no good data to show that one is better than the other or will give better CAR T versus not. And so there's nothing standard to be done at the moment.
Okay.
And
Okay.
I think one thing to add to that is, now that we're moving CAR T up earlier and earlier, we're seeing patients who haven't had a lot of chemotherapy, and so their bone marrow is not as beat up. So we'll learn from these studies, are you going to see response rates that are longer, and are they more durable, right? Than these relapsed refractory patients who've had tons and tons of median prior lines prior. So, your bone marrow is beat up. So one thought is, well, what if you collected your T cells when you're doing your stem cell harvest for apheresis and you just saved it, and then when you need it, you can use it down the road? So I think that's something that people are thinking about. But first we are trying to get our CAR T cell approved and readily available to patients. And I think once we have that, I'm sure more of us are going to think along the lines of what can we do to, who's going to pay for that, right? So we need to figure out all that factors.
Okay, that brings up a really good question that I want to ask. Well, you brought it up yourself, I guess. This idea of maybe freezing your T cells or storing them for later. I think the commercial products won't allow that, right? Won't allow use of the trials, the ones that are in trial. I don't know if they would once they were approved, but in what scenario would that potentially work?
Yeah, I mean, I think when we have been talking to the sponsors who are going to have commercially available CAR Ts, that's something that we brought up, and we said, like, is that something that you guys would do to distinguish one CAR T from the other, right? So maybe if there's like 5 CAR Ts that are all commercially available and you're trying to pick, maybe they'll try to do amongst themselves and say, hey, we can pay for your T cells for storage, early on, and then we can use it for later. I know Kymriah does something similar like that. If they can collect, and if you don't go through CAR T, then they don't really fully charge. So I think a lot of it is going to depend on the insurance and how the CAR T is going to get approved. I know the lymphoma CAR Ts have really paved the way, because when we first had lymphoma CAR Ts, we would have patients who were trying to get on the CAR T and they progressed before insurance would approve. now it's like this basket thing. So if you've had one patient approved on this one particular insurance, then the next patient that comes along that has the same insurance, then the approval is getting faster. So I think they're kind of paving the way for the myeloma CAR Ts for when we become commercial. So hopefully that can be used for us as well.
Mhm. Okay, great. Anybody else have comments on that topic?
No, I think Dr. Madhuri covered it well.
Okay. Think about CAR T use in plasma cell leukemia. Is it appropriate? How do you think about plasma cell leukemia, secondary or primary PCL? Can patients with PCL get CAR T?
Oh,
I think that once commercialized, obviously it is something that theoretically could be given. The issue is going to be, again, these are going to probably be pretty much policed by FDA indication. And so if you label a patient as plasma cell leukemia, it is possible that the insurance may not pay for it, but there is no reason why it wouldn't potentially work for a patient with plasma cell leukemia.
so Ravi, I would think that in most of the studies we have done for all other drug, plasma cell leukemia is always an exception in the studies. But when FDA approval comes, they don't say no plasma cell leukemia. They just say 2-line, 3-line, or something like that. So I'm hoping that even for CAR T, a similar procedure would be followed, and that the approval would be for certain prior exposure or certain line, 3 lines and 3 drugs exposure, but not necessarily exclude patient with plasma cell leukemia, in which case probably insurance company would not have a reason or basis to exclude plasma cell leukemia. That's an hope that that would be the case. And if that is the case, then I would think plasma cell leukemia would be probably one of the most important area where we can make a good impact with CAR T cell, with getting deep and durable responses.
And just to add to that, I think there's a couple of trials that say history of plasma cell leukemia versus active plasma cell leukemia. So a few trials allow history because, you know, maybe that's how they presented, right, with plasma cell leukemia, and they've been treated, and since then they don't have circulating plasma cells. And some trials do allow history. Some, I mean, most all of them pretty much exclude active plasma cell leukemia.
Mm-hmm.
I think an important consideration with plasma cell leukemia is that they may be more likely to have CNS involvement, and given one of the fear toxicities of CAR T could be CNS toxicity, just making sure that that is under control. And it will be important to evaluate kind of prospectively if the patient has CNS involvement and is given a CAR T cell. Is there a way to get it under control before receiving it?
Mm-hmm. Kind of a follow-up question on that is, do you ever pre-treat for cytokine release? Like give tocilizumab or steroids or anything like that for all CAR T patients, or you just have to have the symptom and then you get it?
There are clinical trials looking at different agents as a prophylaxis. There are JAK inhibitor trials, and I think there are some trials even looking at possibility of tocilizumab. But right now it is given for management and not for prophylaxis. But there are trials certainly looking at that.
Okay. And
there is at least a moment that instead of what we used to do 3 years ago, where we would wait for certain clear level of CRS develop before we give it, now all of us give it much earlier. At the first sign of something, we would try and abrogate it. So there are issues whether we do it too early. Would it cause other problem? Would we lose the anti-tumor effect, because the whole treatment is done to get a good tumor effect? And so there are ongoing studies in myeloma, but also in leukemia and lymphoma to understand that. But at least we are all, I'm sure Dr. Madhuri and Vij would agree, we are very quick to do something at the very first sight of CRS.
Mm-hmm.
Yeah, that's right.
And what about patients who are have non-secretory myeloma? I know a lot of those patients are excluded from clinical trials. So are they excluded in the current CAR T trials? And when this is commercially available, everybody could get it, right? I would assume.
Yeah, so the exclusion is mainly because the clinical trials are meant to measure the response. We want to see if the CAR T works or not. And if they're non-secretory, we cannot easily measure. That's not entirely true with all the imaging we have, but that's the tradition. And so that's why they are excluded. However, when commercially available, they would all be good candidates. I doubt they would be excluded from study, although applying the principle for plasma cell leukemia, would that apply here? I think both of those situations will be included in CAR T cell therapy commercially.
Another question about dual CAR T targets. So you talked about GPR C5D. I'm never going to remember that. And BCMA combined. I know there's one trial open for that, right? And then there are some others that are potentially, like we funded really early research on the SLAMF7 and the BCMA target as a dual CAR T idea. I've heard some doctors talk about these early stem cell myeloma stem cells and going after BCMA plus another target. Do you just want to talk about that to potentially prevent relapse or something like that? In terms of target, what do you pick as your second target?
So I'll take it. So CD19 was, I'm saying was, it could be said, is considered as one of the possible marker for stem cell. Although I think all of us who are in the lab research do not think CD19 is the gold standard marker for early stem cell of myeloma. If that were the case, I think combining BCMA and CD19 would be very good. So the door is still open in identifying what is really the early stem cell. And it's a complex question, so I don't want to make it more complex answer. But myeloma cells change. So what is stem cell will become more clear myeloma-like cells, and we do believe that clear myeloma cells can go back and become stem cell-like cells. So there could be some plasticity there. Keeping that in mind, I think currently what is more important is to combine more than one target, not necessarily worry about what is present on the stem cell, and that if we need to get rid of that supposedly stem cell that may or may not exist. And I do mean may or may not exist in the true sense. There are many lab versions of stem cell definition, but in the true sense. And so I think, as Dr. Madhuri said, if we say do BCMA with GPRC5D or BCMA with any other myeloma-like target, I think to me it would be quite legitimate. Using CD19 is a tough one to follow. There are studies ongoing, and I would wait and see what it shows. But I would rather go for more myeloma card-carrying targets rather than go after purported stem cell marker.
Yeah, and that didn't work very well when those were some of the very first CAR T trials, right? CD19
Yep.
in myeloma, and they weren't that great.
No.
Okay, let's talk about maintenance after CAR T therapy. So I know the trials probably don't allow any kind of maintenance, right? Because it's a one and done treatment. You want to see how long the effect can be. But once they're commercially available, what would be your first pick as maintenance, if anything?
So the thing is that actually some of the CAR T cells where they're being given in earlier lines of therapy are actually allowing maintenance after that. These are small single arm studies with very few patients on. So that I think does make sense. The question is, how soon after the CAR T cells should these be started if you give maintenance? Now, on one hand, eliminating maintenance is a good goal because it reduces the need for taking pills long term. It reduces the cost of care. But on the other hand, there is theoretical promise to giving drugs like immunomodulatory drugs, especially, and other drug classes, either in succession or possibly even concurrently. When I say concurrently, maybe within a few days to a few weeks of T cell, but it has to be done in the context of a trial first, because as I said, you could put these cells into overdrive and you could actually end up increasing the toxicity proportionally as well.
Interesting. And what about any others? Oh,
Main issue for maintenance is going to be how do we, so as I said, BCMA loss is not the reason why patients relapse. So what makes patients relapse? And there are many immunological reasons, but most of them appear to be immunological in the sense that the CAR T don't survive long enough and or their characteristic change, what we call exhausted CAR T cell, or the rest of the immune microenvironment of the bone marrow might inhibit the CAR T doing what it does, et cetera, or the trafficking could be issue. So I think, as Dr. Weed said, I think all the efforts or thinking has been to see how we improve the immune function of the CAR T cells or change the microenvironment function. And any of the drugs that we have, and as a list of drug we have, all will be evaluated in one fashion or another to see what works the best.
Mhm.
And I
And-
think just to add to that, I know that BMT CTN, like we've worked with them to design 2 trials right now that are going to test a little bit of this maintenance approach. One is going to be you have induction, then you have transplant, then you do CAR T after, and then do maintenance with Revlimid, right? So like both the other panelists said, I mean, sometimes that you have cytopenias after CAR T for weeks to months. And so if you're giving Revlimid that can cause more cytopenias, then, you know, how beneficial is it? And can these patients actually get on maintenance? And if so, when? So hopefully when these trials are done, we'll get a little bit more information.
And is that the most longest lasting side effect of CAR T therapy? Or are there others?
I mean, you can be hypogamma also for some of these patients. So we typically give them IVIG pre-lymphodepletion and kind of continue it every month for, you know, 6 months, or at least, especially if they're known to have multiple infections, give them IVIG during the winter months. Cytopenias, yes, are an issue, but you know, they do recover their counts. It's just some people recover within a median of like 1.7 weeks. Some recover like 3 months later, you know, so it all depends on how beat up you were before to begin with. And if you have a really beat up bone marrow, then it may take you a little bit longer to recover than normal.
So one of the questions from Graham is, what about repeated CAR T treatments? So if you think about failing a BCMA CAR T treatment, and then going after, you know, the other target, any of the other targets, is it because it's not the BCMA itself, and it might be just the exhaustion of the T cells? Is that a good strategy, or do you do something else?
Okay. Yeah. So, so basically, I think using another CAR T cell infusion is quite wise. And again, partly I'm saying this based on not having enough data one way or another. BCMA has been used as a reinfusion, and there were anecdotal cases who have shown response. So you can even use that. And that is to the point that BCMA still remains a target. But you are asking a very, very astute question, whether if the microenvironment is an issue, then another CAR T would make a sense or not. And that's where we will have to learn something more, whether I would do something in the middle. I might give some other treatment in the middle before going to the next CAR T cell, and maybe not do 2 CAR T cells in back to back. And so that if I give some other 3 drug combination, that changes the microenvironment again or resets the microenvironment, and then we can do CAR T cell. But having at least anecdotal patient respond to the second same CAR T cell, I'm very hopeful that if we change the target, we with some modification, we might be able to get similar responses.
Mhm.
Now, what is going to become important is to have 2 targets on 1 CAR, and that may provide more direct deeper response. And again, you can ask question: is it better to have 2 on 1 or to do 1 and 2 separately? And I think those are all the questions that we will have. It is really an exciting time because all these treatments work. We just have to sequence them appropriately.
Yeah, and that was one of the questions too. Is there any way of, when it comes to looking at remission times? I mean, all the CAR T therapies were done in patients who had 5, 6. I mean, I had a girlfriend who had 18 lines of therapy that did CAR T. And so they're heavily pretreated. And so as you think about it, so you can't really do this accurate comparison between stem cell transplant versus CAR T, because stem cell transplant is being done after a short induction and people going right to transplant. So it's not really a fair question to say, you know, like what's the remission comparisons or anything like that. But I guess maybe I'm answering my own question. You just have to wait and see. I don't know. What do you have to say about that? In terms of,
we really do have to wait and see, right? Because right now, like we talked about, there's a lot of trials that are pending, but Karma is the only one that's given us PFS and OS so far to date because it's the trial that's been around the longest. So we really have to see what the rest of the trials are. But like I mentioned, I mean, these triple refractory patients, their OS and their PFS is already very low. And these CAR T trials, one-time treatment in these really relapsed refractory patients is giving us, 12.1 months PFS. That's really amazing.
It is. It is. And you went over those results, Dr. Munshi too. And yeah. Okay, we answered some questions about MRI. Yeah. There was a question that asked, is there any way of telling how effective CAR T will be after during the manufacturing process at all? Or are there any indications of like I know some patients can't get enough manufactured or something like that. I kind of overheard that somewhere at some point. Maybe that's not correct. But is there any way of predetermining who will or won't respond to CAR T? Dr. Vij, do you want to take a shot at that?
I don't know of anything that one can say can predict response to CAR T. I think people have looked at BCMA expression and not come up with any suggestion that high expressors of BCMA respond and low expressors do not. As to, I think you also were alluding to perhaps even manufacturing of CAR T. Now, the success of manufacturing is something also that could sometimes distinguish products in the future. Now, what we know is that some of these CAR T cell trials, at least, exclude patients who have low lymphocyte counts to start with from even going on to the trial because they think that if you have a low lymphocyte count, you won't be able to perhaps manufacture the CAR T. But I don't think there's any consensus in that area as well.
And the point is that if the response rate is between 80 and 100%, almost everybody is going to respond.
Okay. Okay. Well, the 80%, 80% plus. And then the other trials, it was higher. So in some of those trials, do you know, I know you kind of are thinking early spring or later spring for one of maybe the Celgene BB2121 product. Is there any idea around time frame for the Janssen CAR T? Do you have any ideas?
We do not. I think the reason to guess the ide-cel is because that is already submitted to FDA, and then there is a fixed time. I think, I don't know the exact date, but somewhere around March is when they have to give the opinion, and FDA has to, and so it's in a fixed cycle now. So we would know about the Janssen product, cilta-cel, as soon as it is submitted. Then the clock will start, and we know when we will have. But our hope is that it will also be submitted in 21, and then we will have results during that time.
Mm-hmm. And then Dr. Vij, you talked about manufacturing CAR T cells in a particular facility. Are there any facilities that I know you're from 3 major academic centers? Are there specific projects being done at major centers to develop your own CAR T? I think at City of Hope, there was one going SLAMA 7, right? But I don't know about others.
I think that the larger academic centers, right from Memorial to ours to I'm sure the Farber and Mount Sinai, do have indigenous programs that are starting preclinical development, and some of these are moving into the clinic. We are developing our own CAR T cells to CS1 that are expected to hopefully meet regulatory requirements to get into human trials sometime next year. But what I was also alluding to was manufacturing CAR T cells on site of a commercial product. So that's another area that is being explored in some lymphoma studies where it's a company product, but their model is to try to see if they can give you the kits to manufacture the CAR T cell on site. So they're 2 slightly different things.
Mm-hmm.
I think this is also economically evolving science where what would be feasible, what would be sustainable, and then also practical. And as you said, many major centers have the capability, and not only capability, but we are all doing it, either homegrown in our own lab or some in connection with companies. And we will see where things will end up settling.
Yeah. And Dr. Munshi, you mentioned earlier that you only have a certain number of slots open for patients who are looking for these CAR T therapies. Do all three of you have different strategy recommendations for patients who would like to get into a CAR T in terms of just navigating the trial? I've just had several friends who have kind of been frustrated by the lack of spots, and then how do you get in, and where do you put your name on a waiting list? And we've had myeloma experts say, don't put your name on the same waiting list for the same trial at multiple sites for the same trial, because that's just going to confuse everybody. But yeah, what do you suggest for patients?
I think this is a very difficult place for us and for the patient. And I would suggest to them to do whatever they can and would to get in. And I would not personally discourage them putting name at multiple places. If they are in need of a CAR T cell where they would benefit, one should do whatever, and I would not fault them for it. And I think it may or may not be right. I don't think I would care there. If they put it at 3 places, that's, I think, okay, whichever place it, because what happens sometimes is that one place has many studies and you might hit it better, although it is, you are in West Coast and this center is in East Coast. And so it's not easy, but you might get a slot in there. And on the other hand, the institution next to you on the West Coast may not have a slot for 6 months. And I think if the person needs card, I wouldn't blame them. I think, and I would love to see what my colleagues think here, but I think that's where you have to be selfish. What is good for the patient is what it should be done, and we will deal with our part. So if I have 10 name of the patient on my 100 patient or 150 patient list, and those 10 patient also have the name in Dr. Madhuri and Dr. Vijay's place, and one of them is able to find the slot, good for the patient. And when I'm looking for a patient, the first 5 patients have gone somewhere else, go to the 6th one. So I think this currently, and this question exists in my mind only for next 3-4 months or so. Once commercial becomes available, we would not have this discussion. So for those 4 months, I would suggest do what you need to do to get into the study. I would love to see what.
No, I totally agree with you. I mean, I would totally encourage the patients to put themselves on whatever list. I've had patients who've gone to see Dr. Munshi and put their name on his list and then came to us, went to Penn, and it's totally fine. I mean, we've done CAR T on patients who came from New Mexico, California, Florida, and the thing is, just because you're on the list and we have, like, say 50 people on our list, it doesn't mean every single patient qualifies for the trial at that time, right? Because you have to be progressing, you have to have good counts, like they can't be rapidly progressing. So they still have to be capable to come in, do the screening, get the apheresis. So say, this patient's on 2 sites, but when my trial site had a spot, this patient wasn't eligible. I reached out to them and I said, hey, I have a spot. But then the patient's like, oh, I'm doing well on my therapy, I can't do it right now. But then at Dr. Munshi's site or Dr. Widget's site, maybe they had a spot and that patient's progressing at that time. So, hey, then she could go on that trial there because they didn't have another patient, So I think I totally agree. You should be selfish and you should get exactly what you want. In the end, what we're trying to do is help the patients, and none of us are ever going to get offended that, oh, you put your name there and here, why did you go there instead of coming here? We're all very cordial. I mean, we all shared patients, Dr. Vidge had a patient that I had a patient that he took care of, and Munshi as well. And so, we all are doing what we want to do for the patient.
I totally agree. I couldn't agree more. I think that you do have, and I have encouraged people to go and put their names on multiple lists myself.
Yeah, well, it's a challenge for everybody involved. So when the commercial products are available, will there only be certain centers that can provide them?
I think there's going to be more than few centers would be. In general, all the centers that can do transplant, more or less should be able to handle CAR T cell. There would be some selection involved by the company. So company would want to make sure you are able to do it. It's like allogeneic transplant. But I think there will be many centers available, but centers of certain size. I think there would be some, the smaller place may or may not want to do it because there is some expertise required to manage this patient. I mean, those of us who do it reasonably frequently, we know what to do, what are the key features of significance to keep in mind to treat the patient, prevent CRS, treat CRS. So there are some nuances, but I don't think it's a rocket science, and I think it would be much wider. Its availability would be much wider, but not everywhere.
Mm-hmm. Okay, I have a question. Jani is asking, can you have a CAR T between two auto transplants or between an auto and an allo? And I know that you would probably just do the stem cell transplant, see if you relapsed, do the CAR T, see if you relapsed, do it like that. But
Yeah, I mean, I think right now we don't have any data to say you do transplant, like tandem transplant with the CAR T in between. But I think Dr. Vij has mentioned it before. You can do a stem cell boost. Say like somebody comes in and you want to take them to CAR T, but their counts don't make the requirement right now. So you can always give them like a stem cell boost to boost their immune system to get their their counts to recover a little bit better, so that they could go onto a CAR T. So we've done that quite a few times. But right now, there's really no data on sandwiching them.
Mm-hmm. And on the counts idea, in terms of boosting the counts so they can be eligible, are there any other strategies that you have to improve, like thrombocytopenia or neutropenia or things like that?
I mean, we have the standard, give them Neupogen, or you can do pulse dose dex sometimes for patients for 4 days and to see if it can boost their white count a little bit if their ANC has to be a certain amount. Some trials don't actually care about your hemoglobin requirement, so it doesn't matter what your hemoglobin is, but they care mostly about the platelets and the white count. Some allow transfusions up to 3 days prior. Some require like a 7-day washout. So every trial is different, but there are strategies that we've been trying to mitigate on how to get somebody on a study.
Okay. Okay. There's one question by Michelle. Have you heard of patients developing a cytomegalovirus infection after CAR T? I don't know what that is, and I'm saying it wrong, I'm sure. Would it have any long-term response of a CAR T treatment?
CMV is an infection that occurs in immunocompromised patients, usually after allogeneic transplant, can even after an autologous transplant. And in literally any immune-compromised state, there are drugs that we use that sometimes make people so immunocompromised that they sometimes reactivate CMV, but it's mainly after allogeneic transplant. After CAR T, yes, it can occur because patients are immunocompromised. I don't think that, and it's usually a treatable condition with drugs that we have available. And to my knowledge, there's no data to suggest that reactivating CMV compromises the success of CAR T in any way.
Mm-hmm. Okay. And the last question, I think we talked about this earlier when we talked about heart issues, but there's no renal concern or implications for patients with renal issues to do CAR T, right? And you may have already answered this. I may have been looking at questions, so I apologize.
No, so
if that's
I think it's a good question because there is a creatinine clearance requirement for most of the studies. It's usually 40 or 45. But the other thing to consider is fludarabine. If you're giving fludarabine and your creatinine clearance is a certain level, you do have to dose reduce the fludarabine. So it's part of your lymphodepleting chemotherapy. So as long as you meet those requirements, and obviously anybody on HD is unfortunately excluded from CAR T, just like as they are for any other clinical trials.
Mm-hmm. Okay.
I think we'll have to see whether when commercially becomes available, would we do till say creatinine clearance of 30 or not? And that's an open question. We would hope we can do it, but don't know, right?
Yeah, totally.
Okay.
Hope so.
I think you may have to just dose reduce the fludarabine a little bit more.
Fludarabine is fine.
30 and then take care of that. Yeah.
Whether we would be concerned.
When it's commercially available, we could do whatever we want, hopefully, if there's not a lot of restrictions.
Pending insurance.
Yes.
True.
Well, we're all excited for that. I just want to thank the three of you for joining today. You've been spectacular, just absolutely fabulous. So you gave us a very comprehensive view of like BCMA targeted therapies, but what's actually happening in CAR T cell research. Dr. Vij and Dr. Munshi and Dr. Maduri, thank you so much for joining us today. Just outstanding panel. Thank you.